Thank you everybody for being here. This is our virtual speaker series with Dr. David Ziring, and he's going to be talking about all kinds of IBD tests used for diagnosis and monitoring. And I have to say it's a really good topic because I've been dealing with IBD for 23 years. My son was diagnosed when he was 2 with first with colitis and then Crohn's. Switched to Crohn's when he was 5, and I still get confused about some of the testing. So I think this is a great talk for anybody at any stage of their IBD journey. And also, if you don't know that much about us, you can check out our website. You can join our newsletter, our mailing list there. You can find out about all of our support groups that we have. We have caregiver support groups, patient support groups, sibling support groups, and other programs for patients and caregivers. And also if you guys have any questions, you can put them in the chat. I know some of you put questions in the registration, so we'll try to get to as many as we can after he gives the talk. And I will go ahead and introduce Dr. Ziering. Dr. Ziering has dedicated his life to helping children with IBD. He received his medical degree from Chicago Medical School while earning his master's degree in clinical immunology. He did his residency here, at Children's Hospital Orange County, did a lot of training in pediatric gastroenterology at UCLA, and he is now the associate director of the Cedars-Sinai Pediatric IBD Program, and I'm sure many of you know him from that role. And he has a lot more things in his bio, but you can look that up separately because we want to get right to the talk because it's going to be exciting and we want to have time for questions if people have them. So I'm going to hand it over to you.
Great. And I'm not a huge fan of making large verbose PowerPoint slides and giving dry lectures. So I'm usually used to a little bit more interaction and so if I happen to ask a question and all I hear is crickets, I can make up some answers for you guys. So I'm going to be speaking on diagnosis to monitoring, understanding IBD tests. All right, so my disclosures, I happen to be a consultant and serve on the Speakers Bureau for Prometheus and Regeneron, and I consult with Celltrion, which is a South Korean company. So why do I think a talk like this is an appropriate talk for a organization like Connecting to Cure that helps support patients through their IBD journey in terms of a lot of the feelings and emotions that come along with living with IBD. The biggest reason is that the advent of our electronic medical record that came about through Obamacare brought test results to everyone. And so it really democratized medicine in that my patients often see these test results before I do. And they've already sent me messages and they're already quite anxious and worried about what these test results mean. And so I hope that today I can provide you some of the information to arm you better with the knowledge and understanding that would kind of allow you to take control over your own healthcare. So, as I was saying, a lot of these IBD tests can be anxiety provoking, and you can see that this alphabet soup of IBD testing and what it feels like when all of your lab test results are written in code. So, we have all of these tests that you may see from time to time appear in your portal, and you have no idea what they mean. Um, and it almost takes a medical degree, spending 4 years in medical school to understand what all of these things mean. Things like an ANA or a CMP or a TSH. But I hope to explain a lot of these tests to you over the next, I don't know, 45 minutes or so. And I will try and leave plenty of time for questions. I suppose if there were a way that you could interrupt me and ask questions as we were having this conversation, and hopefully it's a conversation, you would do so. All right. So I'm going to organize this talk in some logical way, speaking about what it's like to evaluate your biopsies, to have imaging studies done, stool testing at the time you're diagnosed, um, but mostly what it's like to live day to day with inflammatory bowel disease and to do both blood tests and stool tests, and at least at a place like Cedars-Sinai, an occasional ultrasound. What it means to have checks on your safety in terms of screening for hepatitis B or lipid monitoring if you're on some of these newer oral agents. And then, um, above all, is maintaining health and promoting wellness. So I'm not huge into disease management.
Hi,
Um,
son. How are we doing?
Hi, everybody. Um, so I'm not into putting out fires. I would rather promote health and in a proactive fashion have patients uh, be empowered in caring for themselves so that I am a companion on this journey, but not necessarily a firefighter. And so we'll talk a bit about wellness too. I feel fine. So why do I need all these tests? The important thing to remember here is that inflammation can be silent, that symptoms don't necessarily match what is going on inside of your body. And we know, as I just said, that promoting wellness and preventing flares can be easier than treating the complications, and they can be pretty awful, the complications of Crohn's disease and ulcerative colitis in terms of malnutrition and blockages in the intestine and holes in your bottom that drain pus. Um, if we are more proactive in care, hopefully we're preventing some of these complications. We know that our treatments work best when we are proactively managing them, when we are using testing to make sure that you're getting the right treatment at the right time, at the right dose. And so it helps us reach our goals as physicians and ultimately a long-lasting remission. So we know that testing isn't about chasing numbers, but about preventing uh, what we call flares. And in fact, I've asked my patients to remove the word flares from their lexicon, that flares should not be associated with inflammatory bowel disease. When physicians out in God knows where are telling their patients, we are all about using prednisone to manage your flares because when you've got IBD, of course you should expect to have flares. No. Uh, if we're doing a good job as physicians and pharma companies are doing good jobs at producing medications that work well, patients shouldn't expect to have flares. And that's what this is all about. So this is a diagram that illustrates the association between disease activity and symptoms. So on the y-axis, you can see the Crohn's disease activity index, which is a measure of how you feel. And on the x-axis is a measurement of the Crohn's disease endoscopic index of severity. So what a scope looks like. And you can see that there's no association here between patients' symptoms and what their scopes look like. It looks like somebody sneezed on the slide. There's basically zero association here. So when did we understand this? We understood this in 1990, right? That was 35 years ago that patients may feel very poorly and have absolutely normal colonoscopies, or they may feel great and have colonoscopies that are really quite scary looking. And so we've understood this for 35 years, but I think only recently have we begun making that message more clear to our patients. Um, and that's why we need to do some of these occasional tests like blood tests or stool tests or colonoscopies or imaging studies, so that we have a really good appreciation of what's happening inside your body, despite how you're feeling. Certainly, how you're feeling is incredibly important to us. Uh, it's important when you're feeling pain or you're feeling fatigued or you're not sleeping or you're feeling depressed or anxious. That's all important to us, and we certainly want to address all of these things as we care for you. But we also want to know what's going on inside of you, deep inside where you may not quite feel it. Um, and so we have these objective monitoring strategies and treat to target paradigms and all kinds of fancy doctor talk. But in the end, we want to make sure you're healed, not only on the outside, but on the inside as well. So, how do our tests complement colonoscopy? Certainly, people don't want to do colonoscopies for many, many reasons. Uh, Having to do the prep the day before means taking a lot of medicine and having a lot of horrible diarrhea. It means going under anesthesia and having an invasive procedure. It means taking off of work. It means asking your loved ones to come take care of you. And nobody wants frequent colonoscopies. And so that's why we do these other tests. We do blood tests, we do stool tests, we do imaging tests in order to complement what we'll see ultimately at the time of colonoscopies. So we know that blood tests like the C-reactive protein and other labs can signal inflammation, and that when we find a concerning lab study, it prompts us to perhaps consider whether we might need to do a colonoscopy earlier. Similarly with stool tests. In fact, stool calprotectin reflects what's happening at the surface level of your intestine. While blood tests capture what's happening in the overall system, the calprotectin is incredibly specific at reflecting inflammation that's happening at the surface of your intestine. And when it's low, it reassures us. And we think, well, perhaps we can wait on doing a colonoscopy another year or two. Similarly, imaging can give us good information about bowel inflammation, narrowings, holes that are happening that are burrowing through the intestine and the rest of your body. And some of this imaging may be more invasive. Some of it is easier to do. Some of it provides us more detail. And we'll talk about this as we get deeper into this talk. Ultimately, the gold standard is colonoscopy, but blood and stool and imaging studies can help us decide when ultimately that is needed. And anecdotally, there are some expert intestinal ultrasound centers like Mount Sinai that have led the way and helped us along our ultrasound journey that use ultrasound in place of routine follow-up colonoscopy. So you'll know that when we start a new therapy, we start infliximab or we start adalimumab, we start one of these newer advanced therapies. We ask you to have a colonoscopy 3 to 6 months after starting a new therapy to verify that it's working the way we intended. Nowadays, we're not doing that. And instead, we are offering intestinal ultrasound because we feel confident in its results. And we feel as if it's going to show us what we might see at the time of colonoscopy. And so there are various studies that are quoted here that let us know that it's important to follow disease activity and not solely how patients are feeling. That symptoms alone may be insufficient, that we need more objective markers. And that's helped us develop these, what we call treat to target strategies. And it gets a little bit in the weeds, but I'll explain it to you. So a whole bunch of experts met in 2021. I want to think that they met in some exotic place in Europe, but they probably met over Zoom. And they came up with these treatment targets, short, medium, and long-term targets that ultimately guide us in how we take care of patients. And so in the immediate term, which is kind of in several weeks to several months, we want patients to feel better, and we want to see that their blood tests are improving and the calprotectin is improving as well. In the intermediate term, we want to make sure that their colonoscopy is looking better and that their biopsies are showing improvement. And then in the long term, we want to maintain a long-term durable remission, reduce complications, and improve patients' quality of life. And so how do tests in IBD help us achieve these goals? Well, calprotectin, again, is a very highly sensitive test that can help us pick up on early signs of inflammation. The C-reactive protein is a blood test that monitors inflammation in the system. And then there are various studies like intestinal ultrasound, MRI, that are non-invasive imaging, monitoring studies, and ultimately colonoscopy that measure healing of the lining of the intestine. Um, okay, so let's talk a little bit about blood tests. There are two inflammatory markers that doctors will keep an eye on. The more important one is the C-reactive protein. It rises as patients develop inflammation in their gut. It's very helpful in Crohn's disease, although it's less reliable in ulcerative colitis. Why is that? Well, patients with ulcerative colitis generally don't have elevated C-reactive protein until they're really pretty sick, until the inflammation progresses through the intestinal wall, and patients end up in the hospital. So, not the greatest monitoring test for somebody with ulcerative colitis, more helpful in Crohn's disease. The C-reactive protein is a blood test that is driven by genetics. And so actually there are some people that don't really have high CRPs. And in those people, it's not helpful to monitor that because we'll never see a significant rise in the C-reactive protein. We can also see CRP rise when it's not related to IBD, when patients become overweight, or at times when they develop a viral infection, or strep throat, or an ear infection. And so there can be all kinds of reasons why CRP can be elevated, unrelated to the activity of inflammatory bowel disease. The sedimentation rate is a bit more nonspecific, and so several of us no longer order it. And it's important to understand the sedimentation rate in the overall context of lab results. It's an older test that we used several generations ago. Neither CRP nor sed rate should be used alone, but they're both used in the context of the bigger picture of monitoring patients. So a little bit more about CRP. It's a simple blood test. It's widely available. It's inexpensive. We can get the results the same day, and it monitors inflammation in the system. It's useful for trends. So we monitor whether it's rising or falling over time. And it generally correlates pretty closely with how patients are doing. Higher CRPs or C-reactive proteins are linked with more severe disease and complications in Crohn's disease. But again, it's not reliable in everybody. It's not great for patients with ulcerative colitis. It's nonspecific. And it certainly doesn't tell us where the inflammation is, just that the system seems inflamed. Hmm. And so when we're not doing blood tests, we're asking patients to inconvenience themselves to collect poop in a plastic hat and scoop it into a vial and drive it down to their local quest and drop it off so that we can get the results a week later. But really, while it's associated with a whole bunch of trouble, it's quite useful for IBD providers. So it's a direct marker of inflammation even better than we can monitor with blood tests. And it correlates very closely with disease activity. In general, lower levels mean that there's less inflammation. And we can check it generally as frequently as we want to, but on the order of once or twice a year. It's obviously non-invasive, and there's no radiation exposure or scope required, and levels of less than 150 are linked with remission in inflammatory bowel disease. It's not disease specific. It can rise with infections, taking Motrin or Advil or Aleve. It can be slightly elevated when you've got polyps or irritable bowel syndrome or celiac disease. Again, it's quite inconvenient to capture stool samples, and it doesn't always match disease location. When you've got isolated inflammation in your small intestine, it's going to be quite low. If you have isolated proctitis or inflammation only in the rectum, you can still have levels that are several thousand. That may cause unnecessary concern in the event of having quite limited disease. So again, it needs to be interpreted carefully by somebody who's experienced in ordering and interpreting these studies. So it's generally very helpful to monitor serially over time, and we interpreted it in context with the location of the disease, patient symptoms, their C-reactive proteins, and what their imaging studies look like. So all of these are puzzle pieces that fit into an organized picture so that we can understand the whole patient. And so it needs to be dropped off within 4 hours if brought in at room temperature or otherwise frozen. Some labs make it even more inconvenient. They'll have you schedule an appointment to drop off your stool specimen. Can you imagine that? They don't just have a window where you can push the vial through with a label on it. You actually have to talk to a teenager manning the Quest lab counter, go online and find an appointment 2 weeks down the road and drop off your stool specimen. And those can obviously be barriers for our patients, and we understand that. Um, Hopefully, one of these days we'll have at-home testing. There's a Swiss or German company called Buhlmann that has developed a really cool test where you obtain your own calprotectin in the comfort of your own home. You smear some on a card. It turns a certain color. You photograph that colored bar with your smartphone. It analyzes it, the intensity of the color, and then it comes up with a calprotectin value. So that's already available in Europe, but not yet available in the US, likely because of regulatory concerns, reimbursement, and challenges with integrating it into the electronic medical record. But hopefully, one of these days, somebody's smart enough to figure out how to get it done here in the US, just as we have with ultrasound. Europe had ultrasound for 20 years before we brought it to the US. So eventually, everything kind of filters down to us. I'd like to talk to you now about IBD antibody testing or serologies. A lot of physicians and even general practice physicians will order these IBD screening panels, but they're not very good for diagnosis or screening, even though they're marketed that way. They can give physicians and their patients false alarms. They're more helpful for determining prognosis or figuring out how aggressive these diseases are going to become and what patients may best be treated with. So they can help predict whether patients are going to develop narrowings or fistulas, these abnormal little tunnels that develop between loops of bowel or from the bowel to the skin. And so leading groups, the American gastroenterology societies that set standards for IBD care don't recommend using IBD screening tests alone to diagnose IBD. They have developed and evolved over time from the early 2000s when I was in training to the 2010s, to the latest blood testing to monitor for endoscopic healing using a blood test. And all of these have their pros and cons, but it really should be physicians who are monitoring these and choosing them in the appropriate patients. So they can help predict disease course. We know that patients who have lots of high antibodies are more likely to develop an aggressive form of Crohn's that requires closer monitoring and more aggressive therapies. It helps us decide who benefits from early effective treatments. But it's just, again, as you'll hear me repeat over and over about these tests, it's one more piece of the puzzle that combined with symptoms, colonoscopy, imaging, and stool tests can help us in our care of patients. A little bit about the tests that we do before we start a new therapy. We do this, what we call pre-biologic testing. We screen for conditions that, when treated with uh, systemic therapies like infliximab or adalimumab or golimumab or upadacitinib or any of the other fancy drugs, could cause problems if these infections are lurking in your body. And so we want to look and make sure you don't have hepatitis B, that you've been well immunized against chickenpox or varicella, and then that we screen for latent tuberculosis, which means tuberculosis that may be hidden deep in your body if you've been exposed to it in the past. We want to make sure that you're well vaccinated, that you've received your live vaccines before starting immunosuppression. And then we do various tests to understand what are things like before we start therapy and how do we monitor uh, your response to therapy to make sure that these therapies are behaving the way we want them to. And we'll talk a little bit about this further. So, in terms of TB testing, the most important TB test is that first one that we obtain. And obviously, if you're exposed to somebody with tuberculosis, we want to know about it. And we also want to know when you travel to an endemic area, certain places in Southeast Asia or other places in the world where TB is more common, because that puts you at increased risk of developing TB. But most of the cases of tuberculosis that happen to patients on these advanced biologics happen with patients who've already had an infection years ago that wasn't recognized at the start. There are some infusion companies, some insurance companies that want these tests done annually, although the science doesn't really support that. There are various tests that we order depending on what medication that you're taking. If you're on JAK inhibitors, like upadacitinib, which the trade name is Rinvoq, or tofacitinib, we'll monitor blood counts and hepatitis B testing and TB testing. We'll monitor blood counts and liver function testing, lipid panels, and we want to make sure you're vaccinated against chickenpox before you start these medications. The old standby anti-TNF medications, the infliximabs and adalimumabs, we do these panel of tests, and we personalize medicine by measuring drug levels and antibodies, and we can talk a little bit more about that in a little bit. And then the newest therapies, the anti-IL-23 medications like risankizumab and the like. Again, we monitor these tests, once every 6 to 12 months. But because we recognize that they are relatively safe, we feel more comfortable not having to monitor blood tests quite as closely as some of the other therapies. Why do we monitor lipids when you're taking a JAK inhibitor like tofacitinib or upadacitinib? Because they can raise cholesterol. They typically raise them in tandem, the LDLs and the HDLs. And then
You said that five times.
I'm sorry.
Well, I'm just
Um,
trying to tell you that.
and so they'll rise in the early in treatment, and then they'll stabilize. And so we may want to repeat them, the lipid panel, at 3 to 4 months, and then ultimately, if we have to start a lipid lowering medication, we'll do that, and that's a conversation that patients should have with their doctors. Why is it important to measure drug levels and antibodies when you are on an advanced biologic like infliximab? Your first biologic, that first advanced therapy that we expose you to, is going to be the most successful that you receive in a lifetime of IBD care. And it's important that we optimize the treatment of that drug from the get-go. And so we say, don't forget your first love, that the first biologic is what matters the most in a lifetime of IBD care. And that's why we are so careful to monitor levels and antibodies against drugs and make sure that you are getting the right dose at the right time and the right frequency. So we talk about things like primary non-response. That's when somebody receives one of these drugs and it never seems to work very well. And we say that perhaps that's not the right drug for the patient, versus a secondary loss of response where a medication may work quite well at first, but over time seems to stop working. Both of these things are relatively common, and that's why we need to monitor these drugs closely. And so that's why we have what we call therapeutic drug monitoring. It helps determine why a drug isn't working, perhaps because the levels are too low, or you've developed antibodies against the drug, or perhaps the drug just isn't the right one for you. And there are various ways of monitoring these things. One is in a reactive fashion when all of a sudden you get sick and we decide to order the test, versus a proactive monitoring where your doctor is more proactive in ordering tests for you to make sure that you're getting the right amount of drug at the right time. And so there's this new idea about precision guided dosing, about monitoring your level after your third dose or with your third dose so we can figure out how much you need at what interval as we plan out the next year of therapy. And so when we do that, when we are proactive and we monitor your level of infliximab with your third dose, and we plan appropriately your ongoing doses, by a year into this particular study, 97% of patients were in corticosteroid-free remission, and we recognized that only 4% of patients were doing well on the standard FDA-labeled dosing. So perhaps it's time that the FDA reexamines their labeling for drugs like infliximab and recognizes that if only 4% of patients are doing well on what they've advised doctors to prescribe for their patients, they should allow doctors to have a bit more flexibility as we provide their doses. Hmm. Now I'd like to get into imaging studies because I know a lot of people have questions about imaging studies. And I'd like to talk about CT versus MRI. And you can see the panel on the left and the panel on the right is the same patient with the same condition. So this is a patient who has a large abscess in the middle of their belly. And that's what all those white arrows are pointing at. And on the left is a CT, on the right is an MRI, and you can see that they look relatively similar, that it gives us about the same information. Perhaps we get a little bit more resolution of the tissues on the MRI than we do on the CT, but there are important differences in addition to that. CT enterography is a quick study. You are in the scanner for maybe 5 or 10 minutes, and that's about it. Anybody can do a CT. In fact, ERs in far-flung places like Antelope Valley will do a CT for everybody who walks through the ER. However, it's associated with a fair bit of radiation exposure. Radiation exposure is measured in millisieverts. I don't know Dr. Sievert, but he's become famous for radiation exposure. And that's equivalent to about 250 chest x-rays. And it requires IV contrast. Whereas an MR enterography, an MRE, is not associated with any radiation. It gives us good detail, but patients have to drink a lot of contrast and they have to lie in the scanner for about 45 minutes. And that can be quite difficult when you're asked to hold your breath and to lie completely still. And having had a liter and a half of contrast to drink, feel the urge to urinate during that 45-minute study. So let's talk a little bit about radiation exposure in IBD imaging. A simple chest X-ray is associated with about 10 days of natural background radiation exposure just walking around here in West Hollywood. A cross-country flight from New York to Los Angeles or vice versa is a fraction of a chest X-ray. Uh, but because you're close to the sun, it's a little bit more than the natural background. An upper GI small bowel follow-through, the old barium swallow studies that we used to do are associated with 30 to 60 chest X-rays. Here you can see a CT enterography and an MR enterography. So you can compare what radiation exposure is like for these various tests. I think that if I had the choice, I would choose an MR enterography if given the choice of these three. Um, these days, we've gotten so good at doing ultrasounds, we feel less of a need to do MR and CT. So you can see those images from before, and the same patient with the same abscess that's identified in those other pictures is now identified in the ultrasound in this first figure, figure 3 of this pretty good paper. This paper, however, was written in 2008. When did ultrasound come to the US? In 2020. So again, uh, US physicians are a bit slow on the uptake. Here you can see ultrasound is done in this patient, has identified this abscess, which is pictured by those arrowheads, and even the early development of a fistula, or that black line that extends downwards from that abscess into the pelvis. And so an ultrasound can provide us just as good information, oftentimes, as a CT or an MRI. I'd like to talk a little bit about nutrition next and how we monitor nutrition. And we'll start with vitamin D because that's one of the most common vitamin deficiencies in IBD and the most common monitoring test that we do when we're monitoring nutrition. So where do people get their vitamin D? It's not from milk or broccoli, it's from sunlight. Most of the vitamin D that your body produces comes from sun exposure. Why is that important in IBD? Well, our patients are worried about sun exposure because of the risk of non-melanoma skin cancers when they're on advanced biologics. Uh, and they are often indoors. They may not feel up to being outside and exercising. They may be using a lot of sunscreen, but we recognize that vitamin D is essential for proper bone health as well as immune function. I've done several studies on how the immune system responds to vitamin D. And so, as physicians, we check vitamin D levels at least annually, if not more frequently. We shoot for a level above 30, often 30 to 50 nanograms per milliliter. And so that may require, if you're not getting enough sunlight, that we provide supplementation in pill form. And we recognize that often supplements of a 1 or 2,000 units a day can be both safe and effective in patients who require vitamin D supplementation. It's also important that we monitor bone health. And I don't touch too much on bone health in this talk, but we measure DEXA scans and bone density, and vitamin D is essential in maintaining proper bone density. Not sure what that was. Okay, I do have a image here of a patient, a pediatric patient, to show you what intestinal ultrasound looks like. This is a patient who has significant bowel wall thickening and what we call Doppler hyperemia. So you see those red and blue and orange signals in the panel on the left. Those are signs of excess blood flow to the wall of the intestine. When your bowel is inflamed, it demands more blood flow. And so that's a good signal that there's inflammation present there. So when we see both swelling of the bowel wall and excess blood flow to a segment of the bowel, we understand that a colonoscopy may show you ulcerations and active inflammatory bowel disease. So intestinal ultrasound is non-invasive. No prep is required. We have real-time information. It's done in clinic. It takes me all of 10 minutes to do. I have a machine in the exam room. I do it at the bedside. It's very helpful for patients who can't sit still for an MRI or a CT, like a child, or patients that we are fearful of exposing to radiation. And it's especially useful in patients who are pregnant because it avoids that radiation and the contrast that we don't want to expose our pregnant patients to. So on the right, you can see that panel of the terminal ileum, the end of the small intestine, and significantly thickened bowel. I hope you can appreciate that. That's 5 and 7 centimeters in bowel wall thickness. That's significantly inflamed because we know the bowel shouldn't be more than about 2 centimeters in thickness. And so that helps us in real time make treatment decisions for our patients. And we can actually show patients at the time of their clinic visit what their bowel looks like. And patients really appreciate that. Okay, so I think that got stuck amongst my talk on monitoring nutritional labs. Next on monitoring iron status. We use obviously the blood counts to monitor for anemia, but that's not quite sufficient for monitoring iron status. It's more important that we monitor levels of serum iron and transferrin saturations, and lastly, serum ferritin, which is the best measure of iron stores, on occasion can rise with inflammation. And so we understand it's measured in context of all of these studies. So when you are feeling fatigued, or you're having ringing in your ear, or you're lightheaded, you're just feeling a bit off, it's important that your doctor is measuring your iron stores. And it's something that I do with routine lab testing. And so it's important that we measure these things. And if we need to supplement iron, that we do it. I prefer IV iron supplementation over oral iron supplementation for various reasons. But again, it's something that you'll want to make sure that your physician is doing on a regular basis. In terms of B12, B12 is absorbed in the end of your small intestine. And so when that is inflamed or it's removed because you've had surgery, you can easily become B12 deficient. And so if you try and supplement your B12 by taking a whole bunch of B12 pills, it's not really going to help because it's got nowhere to be absorbed. And at that point, you may benefit more from B12 injections once every 6 months or so. We recognize that B12 deficiency can cause anemia, fatigue, and sometimes numbness and tingling, changes in memory. And so we monitor B12 on an annual basis, and we give intramuscular injections of B12 when we need to supplement them. In terms of zinc, you may not appreciate how important zinc is in inflammatory bowel disease. But zinc is lost when you've got diarrhea or you're malabsorbing your nutrients. And zinc is essential for your taste buds to function and to regulate your appetite. And so if you are zinc deficient, you are quickly going to lose your sense of taste, and you're going to lose your interest in eating. You're develop what we call anorexia, which is a loss of appetite and resulting poor nutrition. Zinc is important for proper functioning of your immune system, for wound healing and growth in children. When you're zinc deficient, you can develop rashes or hair loss, poor nail growth, decreased taste. And so it's important to monitor zinc and replace it when it's low. So key points in terms of monitoring nutrition: we monitor iron, B12, vitamin D, and zinc. And it matters because deficiencies are common, even when patients are in remission, especially when you are taking therapeutic diets like SCD, or you're taking a diet to help manage symptoms like a low FODMAP diet. Um, and so it's important to monitor these things. Subtle symptoms may signal vitamin deficiencies or mineral deficiencies. And so it's important that we monitor and supplement them to improve quality of life. And then we get into fatigue. So fatigue is one of the most common and disabling symptoms that patients will report to me. And it persists even when patients are in remission, and it's not always explained by lab results or even disease activity. It happens because of various vitamin or mineral deficiencies. It happens in the setting of inflammation. It happens when patients are have disrupted sleep, or they're depressed or anxious. It happens in relationship to side effects from medications. But sometimes we have no idea why it happens. We just appreciate that patients are battling horrible fatigue. And so how do we manage fatigue? Obviously, we tell you to charge your phone in the kitchen, not to cruise TikTok at midnight. We correct vitamin deficiencies. But sometimes, because of studies that have been done, we'll provide high dose vitamin B1 or thiamine. In select cases, we've begun using a medication called modafinil, which is used for narcolepsy, but it has been proven to help patients with chronic fatigue and IBD. And obviously, we encourage physical activity and exercise because even that can help with chronic fatigue. So fatigue affects up to 70% of our patients, and it's important that we ask about it and we address it because it really impacts patients' quality of life. And then we get into anxiety and depression. So not only does seeing a result pop up in your patient portal generate anxiety, but we recognize that 40% of our patients are battling anxiety and fatigue. Crohn's disease and ulcerative colitis are all about waiting for the other shoe to drop. What the next test will show is a frequent concern. We recognize that it's important that patients are empowered by having access to their test results. But we recognize also that abnormal numbers without understanding their context can increase anxiety. And as you're waiting for your physician to respond to your questions about your lab results, as it gets into 24 or 48 hours later, your anxiety only ratchets higher and higher. Even small lab changes, C-reactive protein or calprotectin, if it goes from 35 to 75 on your calprotectin value, it can cause patients to become quite worried. And so it takes a physician who's taking care of you to be able to kind of walk you through what that means in the context of your particular disease. Everybody has their own Crohn's disease. Everybody has their own ulcerative colitis. and no two patients are exactly alike. And so we want to discuss these things together and offer support to those who feel anxious or depressed. I want to talk a little bit about cancer risks. We know that there are certain medications that increase cancer risks, especially thiopurines, 6-MP, azathioprine, to a lesser degree, anti-TNFs, and certainly patients who receive combination therapy are at highest risk of developing cancers like lymphomas. Patients who have liver conditions like primary sclerosing cholangitis associated with their inflammatory bowel disease have other cancer risks that, again, your physician is monitoring and concerned about too. So what risk factors are modifiable? How do we reduce the risk of cancer? Go in for your annual skin checks, have adequate sun protection, have regular PAP screens or HPV screening, make sure you're immunized if you're young enough against HPV. I personally don't prescribe thiopurines to my young patients because of the risk, even though it's small, 6 out of 10,000, it's still appreciable in young men and women. And we perform monitoring studies in those who have this particular combination of primary sclerosing cholangitis, this particular liver disease associated with their inflammatory bowel disease. So they are real, but they're small. And so it's important that we do proactive monitoring and prevention. So what detects cancer early? Colonoscopy does, especially in those who have had longstanding ulcerative colitis, because it can detect the earliest signs of colon cancer. And so we do routine screening for colon cancer in patients who've had more than 8 or 10 years of ulcerative colitis or Crohn's disease of the colon. We schedule these every 1 to 3 years so that we can detect those earliest signs of cancer and treat them appropriately. Are there other tests that help tip us off to the presence of cancer? Not really. C-reactive protein and calprotectin track inflammation. They don't track cancer. We can't really do fecal testing for occult blood. We can't do those fancy stool tests to detect cancer because they're not reliable for patients who have IBD. Imaging studies, again, are good at picking up inflammation, not good at screening for cancer. There aren't really blood test screens for cancers. And so the one test that you can do is your surveillance colonoscopy when you fall into those risk categories. So colonoscopy is really the only proven tool for early cancer detection in IBD. I've got patients who use diet as therapy, who use herbals as therapy, and I'm supportive of those kinds of treatments as long as we monitor them carefully. And so, how do I monitor those patients? I monitor by checking calprotectins on a routine basis, by doing intestinal ultrasounds in clinic, and combining those results with symptoms in order to develop a full picture of what their Crohn's disease or ulcerative colitis is doing. And if calprotectin or ultrasound suggest inflammation, then it prompts me to do a colonoscopy and help guide decisions together with patients about choosing alternative therapies. And so diet and evidence-based herbal therapies can be part of IBD care, but require careful monitoring. On that front, I'm doing currently a study, if anybody's interested in using diet as therapy, of patients' attitudes about monitoring strategies, and particularly intestinal ultrasound for helping guide therapy when we're using diet as therapy to treat IBD. All right, one last plug for intestinal ultrasound. These are my last slides, and then I'm happy to take questions. I'm sorry if I've run over a little bit. So for intestinal ultrasound, because I happen to be advocacy committee chair for the Ultrasound Society of Canada and the US. Um, for patients, ultrasound is non-invasive, it's free of radiation, it's repeatable. Results happen in real time as I've got the probe in my hand and the patient by my side, and we can have that discussion together in clinic about their therapy and how well it's working. And it reduces the need for CT and MRI and frequent colonoscopies. Hmm. Why don't more physicians do intestinal ultrasound? There aren't a whole lot of opportunities for training. Equipment costs are quite high, and some health systems don't want to make the investments in the intestinal ultrasound equipment. Um, uh, some insurance companies don't reimburse and ask patients to carry the financial burden of paying for intestinal ultrasound. And many clinicians outside of IBD centers like Cedars don't know much about intestinal ultrasound. And so I'm going to ask you and patients out there to advocate for physicians to offer intestinal ultrasound to their patients. Is intestinal ultrasound an option for me? If you've had one, share your experiences. Advocate for training, reimbursement, and access because patient voices matter. Payers, insurance companies, hospitals listen when patients demand intestinal ultrasound as part of their IBD care. You have powerful voices, and together we can drive health systems to invest in this modality. That's it, and I'm happy to take questions.
Sorry. Thank you so much. That was really fantastic, and I really appreciated going over all those tests again. We did have a few questions that we got beforehand, and then maybe some people have questions now, but you touched on this a little bit, but someone said, what are the limitations of intestinal ultrasound, especially in thin adults?
Actually, in thin adults, it's easier to do intestinal ultrasound than in adults who are heavier because there's less tissue between my ultrasound probe and their intestine. Um, Typically, the small intestine is more prominent, and so it's a little bit more hunting around. In general, the limits to intestinal ultrasound are it can sometimes be difficult to visualize the rectum. And so for patients who have isolated proctitis, I have trouble appreciating what's going on in the rectum with my ultrasound probe. It's just very deep in the pelvis. It's below your bladder. It's hard to get to with the ultrasound probe. Similarly, I can see the end of your small intestine. I can see the ileum, but I can't see the rest of the small intestine. And so the intestinal ultrasound is really good at showing me the majority of the colon, the end of the small intestine, where 95% of patients have their disease. But for patients who have isolated small bowel disease or who have isolated proctitis, it may not be the best test for them.
Okay, that's interesting. I didn't know that because, yeah, someone also asked the question about ileal strictures, but you said you
Yeah,
could.
if patients have ileal strictures, ultrasound can be very helpful because I can identify how thin the opening is and the length of bowel that's involved. And I can describe that to your IBD treating physician. I can say there's a 4 centimeter area of area of narrowing, and it's narrowed to an opening of about a half a centimeter, so that certainly smoothies can get through, but it's going to be very difficult when you have a 48-ounce T-bone steak for that to make it through a half centimeter opening.
But you can't really see strictures higher that are in other
I
parts of
can't see strictures above the ileum. No, that's what we need MRIs for.
Okay, that's interesting. I didn't know that. Um, did you
Even I taught you something, Stacy.
I know you taught me something. Another question is, do you ever diagnose with capsule endoscopy? I think this question meant capsule endoscopy with strictures and ulcerations. Meaning, do you see strictures? Because I know there's concern about doing that if you suspect strictures.
Yeah, so a capsule endoscopy, I don't think I have one here, but a capsule endoscopy is about the size of the end of your thumb, the last joint of your thumb. And so you can imagine swallowing that plastic thing with a camera and batteries and a transmitter inside of it. that it has to travel all the way through your small intestine and end up coming out in your poop, that if you've got a narrowing, we're probably not going to send that through because it's going to get stuck somewhere. But it can definitely show us ulcerations. We are just very careful not to give it to patients that we are worried that they've got a tight stricture that the capsule is going to get stuck behind, because then
Yeah.
we have to figure out how to retrieve it, and it's not the easiest thing to do.
Yeah, like when my son had done them in the past, they would give the fake one, the one that dissolves to see
Hmm.
pass through before the
Yeah.
mechanism strictures. Betty asked a question about serology helpful in determining a patient's disease course. Does this have to be done at diagnosis?
No, it can be done at any time. Uh, Um, I, a lot of this groundbreaking work was done at Cedars. Prometheus actually was formed by our leadership, Steph Targan and John Braun. They were the ones who developed that testing, and we recognize that you can obtain that testing at any time. And depending on the pattern of antibodies, how high or low they are, how many there are, it can give us patterns to identify which patients are at highest risk then of going on and developing further narrowings and fistulas and other kinds of problems that would require more effective therapy.
Thank you. Um, and then let's see. Brian asked a question about are there, you talked about in the beginning about how people get their results in their portal, like before you see it, and that happens all the time. But, patients want to see the results, but yes, it can be concerning because they don't know how to interpret them. Is there anything that you would not send to the portal, like a scenario where something's so alarming that you wouldn't, or do you have no control over that anyway?
I have little control over that. I'm trying to think I think there are certain tests that aren't automatically shared with patients, like HIV results, for instance. Um, where those are results really we want to have those conversations with patients and don't want to just plop that in their laps. I would think that if we have a biopsy and it shows the earliest signs of colon cancer, that's something that I want to be able to share with my patients on a one-on-one basis, and not have them see that and feel confronted by that realization in their face all of a sudden without feeling supported. So, yeah, there obviously are some test results that I'd rather be able to talk through together.
Yeah.
Um, then again, when patients are severely anemic, if their hemoglobin is 6 or 7, I'm going to get a call from the lab as I'm, on my way home from clinic saying, your patient has an alarming value. Please reach out to them. So some of these test results, I may not see if they're mildly abnormal, but if they're severely abnormal to the point that they're really threatening your health and welfare, it's something that I'll receive a phone call about, and I'll reach out to you.
Okay, that's good. That's good to know,
Hmm.
actually. Actually, you mentioned something that I found interesting also. I think what you said about ferritin, about sometimes the ferritin level can be up if there's inflammation. Is that what you said?
Yeah, yeah, because it's a protein produced by your liver, and it enters your bloodstream, and when your body's inflamed, those values can be a little bit higher. And so we have to take the absolute value into context of inflammation when evaluating iron stores. And so we look at all of these pieces together to figure out, what is your iron status, and do you really need to be supplemented?
Yeah. No, I actually think there was a lot of things in this talk that we'd like to maybe make into some kind of graphic because even like the thing you said about zinc, zinc, what can happen when you're zinc deficient was really
Mhm.
interesting too. And I don't know if that's even something like, would you test that once a year with some of the other, like the B12 and things
I
like that?
do. I
Yeah.
do. I think that if your physician, your IBD treating physician is up on their nutrition and providing holistic care, that they should be checking these things from time to time.
Mhm.
Certainly, our IBD nutritionists are expert on these, but physicians should be well trained and monitoring these things too. And because zinc is so important for not only wound healing, but also the function of your taste buds and your appetite. Whenever somebody is sick with IBD, I'm checking zinc levels and supplementing it. Um, would you know it? But zinc Ease lozenges are zinc. And so sometimes patients who are zinc deficient can suck on those lozenges and get enough zinc into their bodies to supplement their zinc, and they don't need a prescription strength of zinc. So there are all kinds of tricks that we'll recommend to help supplement these things.
Yeah, that's interesting. Okay, another one, last question maybe, or if anyone else has anything after this. Michelle also asked, do you know if there's any UCSD people who are trained to perform IUS?
Um, I don't know off the top of my head because the faculty at UCSD has such high turnover that anybody at the moment is trained in intestinal ultrasound. Um, Not that I'm aware of, but I can always do some research and find out.
Is there a way for patients to find out? Like, because you talked also about, spreading the word, which I think is really important. I think Bob
Yeah,
also meant we were talking about that when we went to the Women's Health and IBD conference, that so many, hospitals, I mean, we're at Cedars, obviously, it's an excellent care, and Mount Sinai, but there's so many hospitals like that don't have this, or even, practices, obviously, that don't refer for it. So, is
yeah. And if you're in a major city, there's bound to be somebody doing intestinal ultrasound. So in Seattle or Houston or Chicago or New York, Atlanta. Um, but yes, if you're somewhere in South Dakota, Nebraska, or Alabama, you may not have a provider close to you that does intestinal ultrasound.
Mhm.
We have a website, the IUScan, what is it, intestinal ultrasound of US and Canada, has a website. I would hope that we have a roster of physicians there that do intestinal ultrasound. If not, I'll make sure that it goes up because that's part of my charter. So I'll make sure.
Yeah.
Um, and anybody can come see me to do an intestinal ultrasound. I'm happy to take anybody who feels like they would benefit from intestinal ultrasound. So yes, if you've got a PPO and want to come to Cedars to do intestinal ultrasound, just reach out to us and we can arrange it.
Mhm.
Um, if you need a referral from another physician, your primary IBD treating physician or your primary care doc can also refer you to us.
Great. That's really helpful. Thank you.
Yeah.
Does anybody else have any other questions? So you just want to ask or put in the chat?